to the recording. Welcome. We've got Wendy who's presenting again for us on neurovascular assessment, and it's one of those topics that sometimes as an orthopaedic nurse you just think, well, neurovascular is straightforward, but it's not until you start thinking about it and looking at it in detail. There's actually a little bit more to neurovasculars than we think and we appreciate, and it's something that's worth taking time to consider in these sorts of forums, and then also incorporating that sort of stuff into your practices as well. So, and I've been to a few presentations at ANZONA where people have spoken about different elements of neurovascular assessment, and it's quite, a little bit more complicated than sometimes we give it credit, I think. So, thank you, Wendy, and I'll hand over to you.
Oh, great. Thanks very much, Paul, and thanks to everyone who's joined us today. As Paul said, I think it's something as orthopaedic nurses that we can use to differentiate ourselves as well as specialist nurses, that this is something that we can do very well and provide that higher level of care and safety for our patients too. So the patients which require neurovascular assessment were pretty much all of our orthopaedic patients. So patients undergoing spinal or any limb surgery, so our elective patients are also trauma patients, anyone that's had a back, cervical or limb injuries, and that doesn't necessarily have to be fractures. That can also be soft tissue injuries which may provide neurovascular compromise, particularly our crush injuries. That's something we need to be aware of. Patients that have had different nursing interventions, so for example, patients that have newly been put into traction or the traction's been altered, that's one stage where we need to be keeping a good eye on their neurovascular status, because what's happening is the traction is lengthening those compartments, as we saw in our compartment syndrome presentation last time, and that if there's too much weight on it, that can actually be causing problems with our neurovascular status. Any newly applied or altered POP or casts that go on, or anything really that's going in a circumferential, so even bandaging. And again, that comes back to the traction too, where the bandaging around a limb, we need to keep a close eye on that once that's been done. Patient with spinal cord injuries, and any patient for any reason that is suggestive of any altering neurovascular status, we want to keep an eye on. Few things that we need to keep in mind before we actually start is that we need to do preparation to be able to properly have a look and assess that area. So removing any nail polish, as much as we can, getting any dirt off, particularly for trauma patients, removing blood, and also the surgical antiseptics that are quite coloured, maybe also altering our view of the limb to be able to assess it properly. Another thing that we need to do is make sure that we've got a good source of light so that we can properly assess. One of the things we do is first of all assess the unaffected extremity first. We've got a lovely baseline of observations sitting there for us. So what we want to do is find out what is the normal for that patient's limb. If patient's an elective preoperative, we want to be getting a baseline and do that of both limbs, not just the limb that's going to be operated on. Because again, when we're looking at comorbidities, we want to know what is the normal for that patient. Is there already a difference within the two limbs before we've started assessing and before they've had any intervention such as surgery done? If a patient's a trauma injury, we want to do it as early as possible, and assessing that is really critical, because what we want to do is we want to try and help differentiate whether they've actually had neurovascular impairment as part of their injury, or is it the subsequent treatment such as the plastering or the circumferential bandaging that's actually causing some impairment. So the sooner we can get that done, the sooner that we know what's happening with the limb. We want to make sure that we've got adequate access to the limb. For example, when we do have patients that have had casting done, being able to have a look and check, particularly with your wrist injuries and POPs around the hand, that we can actually adequately assess the movement that they're doing. And we'll come into that a little bit when we look at the individual nerves that we're assessing. Before we even start, we also need to know what's their medical history and what are the comorbidities that we need to take into consideration as part of our assessment. And this is a really good example of what we're talking about here with chronic limb ischemia secondary to someone with diabetes. So again, that's another really, really good reason that we want to be assessing the affected as well as the unaffected side and getting that baseline as well before we start. How do we assess? The main sort of things that we're looking for that we do know is our colour of the limb, the warmth, the movement, the sensation, pain, which is probably your most important sign that we're going to be looking for, and the most reliable sign of neurovascular compromise. And also pulses, which was one of your least reliable signs, because pulses can still be present, but a patient's neurovascular status can be really quite compromised way before we lose the pulses to that limb. Quite a few other things that we can also assess for, and particularly patients that have had a nerve block done, or your unconscious patients, these are who are unable to cooperate with the movement and sensation reporting back to us. What we can look at is for the presence of edema, the tissue turgor around the limb, to see if there's appropriate positioning and elevation of the limb, because we're always thinking of prevention along the ways. We want to know if there's any factors which may potentially compromise neurovascular status, so that again it's giving us a nice high level of suspicion that we can be really alert to and keeping an eye on them, and also the capillary refill time. When we look at the colour of the limb, and again coming back to our baseline of the other limb, that's giving us a really good comparison to have a look at. Whether the skin is pink, and again, this depends on the skin tone of the patient, because obviously that's not going to be necessarily a good description for all of our patients, but is it normal for their skin tone? If it's
Sorry,
looking
Wendy.
like, yes,
Sorry,
yep.
Diane was just asking a question about Turga.
Okay, well, sorry, I didn't get that one that came up on my screen. Oh, mine hasn't scrolled down. Tissue turgor is very much when you do see a limb that has been, particularly a compartment syndrome, what you're seeing is that tissue turgor is, how much give the tissues have actually got. So you'll see a really, really tense limb, and not necessarily for different types of nerve damage, but your compartment syndromes where it's caused by the edema in the area, the tissues just become very, very tight. They can actually feel like concrete. You can actually feel like you can, knock on them like a piece of wood. So it's looking at the turgor as far as all of that, because you should, still have skin that you can just pinch on the top of without it being too tense and too tight. So that's what we're talking about with tissue turgor. So my chat bit just didn't scroll down, so I didn't see that, but I've got it scrolled down now. Okay, when we go back to colour, blue or white might be indicative of inadequate arterial supply to that limb. And if they look very red, if they look quite congested, sort of appearance, that may be saying that there's inadequate venous return that's happening. We saw this next slide in our compartment syndrome talk, but it just is a really, really good example of assessing colour. And this was a patient that came in with a knee dislocation. And straight away, when we look at their left foot, which is on our right-hand side of the screen there, we can just see straight away that dusky appearance. And we know that certainly that, foot is not getting a good blood supply to it. And again, looking at the baseline, because we've got the their right-hand foot on our left, which is, giving us a lovely comparison there. And certainly we know with knee dislocations, because of the way that the vessels travel within that popliteal space under the knee, they are certainly at risk during that time. Okay, the next thing that we move on to is looking at the warmth of the limb. And this is really where the comparison is very much needed with the other limb, because I know for myself, if you were to feel my feet right now, they would be really lovely and cold, and that doesn't necessarily mean that there is a problem. It's just that's obviously my baseline. So if you're feeling the difference between the two limbs, that one is feeling very, very hot, that again could be that venous congestion, and it could be suggesting inadequate venous return. And if it's feeling cold, and for anyone that has felt someone with neurovascular compromise, it can be a really cold, icy cold feel that would be suggestive of an inadequate arterial supply of the limb. We next move on to pain, and this is one of the most significant subjective signs of neurovascular deficiency, and certainly a very, very reliable sign and something that should be setting off alarm bells for us. And what it is that we're looking at a pain that just doesn't seem to be in relation or in the right context for the sort of injury that they have. We're looking at the analgesia and what sort of analgesic effects that they're having, and certainly if we've been giving them analgesics, we're looking, if that's not having an effect and their requests are getting more and more, that could be very, very suggestive that there is a problem with that as well. It's progressive, it becomes more severe, it's unrelenting, and no matter what we're trying to do with narcotics or whatever opioids we're trying to use, that's a real warning sign for us. Right. Also, we'll have a little look at the neurovascular assessment of the upper limbs. And it's three main nerves that we're looking at that supply the hand. And they are the three main nerves that we're looking to test. So first of all, the radial nerve. We also have the median nerve and the ulnar nerve. And we'll go through these one by one. We look at the path of the radial nerve, and that's just shown there in yellow. What we can see is it's coming down the arm, it's wrapping around the humerus. It actually sits in a little notch there as it wraps around, comes past the lateral part of the olecranon, and it's going down, crosses across, and then it's supplying around the thumb area. When we looking at the sensation, now if all of us were to test the sensation of our nerves to our hands, we'd find that the areas of distribution would probably be quite different for all of us. But what we do find is that there are particular areas that tend to be the true sensation that is common to most people. And we find that back of the hand with the radial nerve and the area around the thumb. So a really good place to test for sensation of the radial nerve is between the thumb and the first finger, and just feeling in that area and getting the patient to tell us what they can feel. Again, use that other limb as a comparison and make sure that that's feeling the same for them as well. The movement is dorsiflexion of the wrist, or pulling that wrist up towards your face. Some people will call that extension of the wrist, but it's basically the same thing. But what we're looking at is dorsiflexion of the wrist. When we were talking about plasters and plasters over the wrist, obviously, depending on what the injury is, some patients may not be able to dorsiflex that wrist. And if they can't, what we do is we ask them to extend their fingers again towards their face to assess the radial nerve. Okay, median nerve. What we're looking at is the top one of those two yellow nerves that's coming down, travelling right through to the centre of the hand. Excuse me. Whoop, sorry, they're just gone a bit out of order there. Okay, so median nerve is supplying half of the hand, mainly on the palmar aspect of the hand. And we can see that the true position and a really good place to be testing it is that middle finger with that as well. When we're testing the movement, it is the opposition of the thumb to that little finger and being able to bring that thumb right across. And again, that will depend on a plaster, and sometimes if the plaster is just covering that thumb's MCP joint and doesn't need to be, maybe we can just trim that plaster back to allow us to be able to assess that properly with them. If plasters are cut way too far up the fingers when they don't need to be, they're really stopping us from being able to assess this properly. The other thing is if they can't do that because they're being held back in a plaster or a cast, what you can do is get them to flex from their MCP joints or their knuckles and put their hand into a fist, and that's another movement which is done by the median nerve. Ulnar nerve, which is the bottom one there in yellow, what that is doing is coming down more that lateral aspect of our arm, and that is supplying round our little finger, okay, our ring finger and our little finger, and it's on that lateral aspect of our hand that we're feeling. Okay, so when we're assessing hands, what we want to do is we want to feel between the web space between their thumb and their first finger to test radial. We want to feel at the end of their middle finger to be testing median, and on that lateral aspect or that little finger to be testing ulnar. And when we look at the movements of our ulnar, it's the abduction of the fingers and allowing all of those movements. And again, if they've got something that's over their hand or their wrist that's not allowing them to abduct their fingers, it also does your PIP and your DIP joints and the little intrinsics within your hands. So maybe you can just get them to be, bending their fingers from the top of their fingers there with their PIP and DIPs to be able to have a look at that. When we look where that travels, and this certainly will come in for our paediatric patients that we have a look at, any of the elbow dislocations or injuries around the olecranon, median and ulnar nerves are certainly at risk for those injuries and areas that we want to have a look at. Okay, when we've got a patient that we necessarily can't be cooperative with the movement and sensation, or as we say, an unconscious patient or someone with a nerve block that's unable to report on all of that for us, we can have a look at some of the positioning of the hand for them, and some of the positions that their hands are going into may also be indicative of problems with their nerve damage. And that's just a good slide of it there as to a claw hand from ulnar nerve damage, what they call an ape hand from median nerve damage, or the wrist drop through losing that dorsiflexion of the wrist that may be indicative of radial nerve damage. Okay, moving on to our lower limbs. What we're assessing is we've got the sciatic nerve coming down, and then that bifurcates into two different nerves, so your common peroneal nerve, which further bifurcates, and your tibial nerve. And so it's peroneal, tibial are the two main ones that we will be assessing for the lower limbs. So looking at movement, common peroneal nerve and tibial nerve. What we have is for common peroneal nerve, it is dorsiflexion of your foot or pulling it up towards your face. And for tibial nerve, it is plantarflexion or planting your foot on an accelerator, which is a nice, easy way to remember the difference. And that's tibial nerve that we're having a look at. For common peroneal nerve, we know that that's travelling down this lateral side. It actually crosses over the top of the fibular head, and then it crosses and it supplies, very good spot to try and test it, is that web space between the great toe and the next toe there. And that's, a true indication of where it needs to be. Okay, for tibial nerve, what we're looking at is the sole of the foot, and we can see that that lateral aspect of the sole of the foot is a really good place to be testing for the peroneal nerve. When we come down and we're checking pulses as well with our lower limbs, we're checking dorsalis pedis. Again, if you run your fingers down, you'll find a tendon that you can feel that comes just between the great toe and the next toe, and then keep moving down and, until you feel dorsalis pedis. And around the medial side, just below medial malleolus and a little bit further down, is where to have a little look at posterior tibialis 10% of the population apparently don't have it, so you may not be able to find it. And the other thing that you can do is assess it with Dopplers to see if you've got it. When you do find it, do the next shifts a big favour, get an Artline non-washable pen and mark them. Put an X marks a spot, and that will make it a lot easier for them to be able to find. Okay, we showed a slide a little bit earlier of a nasty knee dislocation that had been indicated and a person that had neurovascular compromise of that foot. We can see just why, because we've got nerves that have been completely impinged that are supposed to be travelling down, sitting within that popliteal space. Popliteal space is completely gone there, and you can think any of the nerves and vessels would be, really quite impinged within that area as well. So anytime I've got a knee dislocation, it's an absolute orthopaedic emergency, and we can see why it's very common to be compromised. Okay, and they're the structures that would actually be impinged within that last slide. Right, when we talk about the common peroneal nerve, I also just mentioned that it crosses over the top of the fibular head, and this has quite a lot of things that we need to think about from an orthopaedic point of view, because if you think about some of the casts that we put on patients, we want to make sure it's running very, very close under the skin there, very, very easy for it to be impinged. Think about any of the circumferential bandages that we're putting on to that area. We make sure that that's protected. And certainly when we're doing skin extensions and different types of traction, that we quite often will put a bit of rest-on foam in there and actually pad the peroneal nerve, the fibular head, to make sure that the peroneal nerve is protected there. But it's really important to see, if you're starting to see some foot drop within your patients, have a think about your common peroneal nerve and whether that's being damaged. Any alteration in neurovascular status, if we're suspecting it, straight away make sure that the limb is elevated. And I think that's something we automatically do as orthopaedic nurses as well, that we're making sure any patient with either an injury or if they're post-operative, that we're elevating the limb to be preventing it from happening in the first place. If it's lower limbs, quickest way to elevate the limb, and a really safe way to do it, is just to get the end of the bed and tip it up. Okay, you can have it on a couple of pillows, but rather than putting it on too many pillows and having it a bit precarious, get the end of the bed and elevate that up. Any injuries or surgery from the elbow down to the hand, what we're wanting to do is get them up into a sign sling or some sort of sling that's getting it up nice and high as well. You can put it on a couple of pillows, but putting them into a stop position and a stop sign position will work much better for elbow and down. Again, if you're suspecting anything, release any constrictive dressings or any plasters. Better that they're cut rather than having neurovascular status compromise. Inform your medical staff straight away, let them know, and start monitoring the status really quite frequently. Little couple of hints for assessing it in children. It may not be quite as easily as just saying, look, extend your wrist or whatever. What you need to be doing is, because again, we know that pain's one of our main indicators, is chatting to the parents or the carers of the child and get their indications and their input as well to find out how comfortable the patient is and whether they're in quite a lot of pain within that. Some of the little movements that you're doing, particularly for the hand movements for radial, median and ulnar, you could make a little bit of a game of it, like make some little stars for me and twinkle, twinkle, little star, and that's getting them to wiggle their fingers, and also you can get them abducting their fingers at the same time. Can get them to do a little fist pump with you, and that's put their finger into that position over to the other side. See how you can make it a little bit fun. The other thing is looking at their movements when they're not realising that they're being assessed. So if they're drawing with a pencil or doing some sort of little play activity or an art activity, and have a look at the movement of their hand to see which of those three main movements that they're doing. But just keep the parents or carers in mind, because they'll also be able to help report with what is normal for that child as well. Really, really important part of anything to do with neurovascular status. If it's not documented, it's not done, okay? And it's just making sure that we've got nice, clear documentation so that we're passing on, you know, what is the baseline, what have we been seeing, has there been any changes, what have we done if we have suspected any alteration in neurovascular status, making sure that's documented. Quite a lot of orthopedic areas will use different styles of neurovascular charts, and some of the neurovascular charts I've seen are really quite good, because rather than saying colour, warmth, movement, sensation, they'll actually provide a table or a description of the movements that they're supposed to be doing, or the sensation areas, and they, you know, a little bit more prompting in what needs to be done. And certainly if we're having less experienced staff that are coming into our ward areas, you know, agency staff or whatever, excuse me, the more prescriptive that we can be with our neurovascular charts, the more help that we can provide, you know, for the safety of our patients as well. So just have a look at that, and certainly that's something that we can share through ANZONA, is some of the documentation, some of the charts that we've got that may help all of that within the clinical areas. So in conclusion, what we're looking at is colour, warmth, movement, sensation, pain, which is a very, very important sign and should make us very, very suspicious. Pulses, capillary refill, making sure we've got good documentation, and that prevention and early detection are essential. And as a resource, what I will do, and I popped it on our compartment syndrome presentation on our Facebook page, but I'll add it to this one today, is the Royal College of Nurses over in the UK have done a really wonderful work on neurovascular assessment, run by Brian Lucas and quite a few of the very experienced orthopaedic nurses over there. And they've come up with quite a lot of consensus and looked at the evidence as based with neurovascular assessment. And unfortunately, trying to get level 1 evidence is very, very difficult, because there isn't a lot of studies to try and back up what we do within neurovascular assessment. But what they certainly have done is got a lot of consensus opinions, also including looking at the frequency of neurovascular observations, because that's a question that comes up just about every time. How often do we do neurovascular obs? And when you look at the evidence, there isn't actually evidence to be able to back it up there through the literature. And certainly it's something that would be really, really good to research. But as a panel of experts, what they came up with was for patients that are at risk, hourly for the first 24 hours, and then being assessed after that time and being done less frequently. But you may want to be able to Google that with the Royal College of Nurses with neurovascular assessment and have a look at the documentation they've done, because it is a really, really good resource with what they've done. And lastly, just a little reminder that we hope to see you in Perth at the end of next year in October 2017 for the ANZONA conference. All the work's well underway and it's going to be great. So I hope to the people that I haven't met that we'll get to meet you then. So thanks very much, and I'll just open the chat to any questions that you may have. And I just seen Paul's just put the link there for people that are not on Facebook to that RCN document, which is very, very good. So thank you, and I'll just see if anyone's got any questions.
Excellent, thank you, Wendy. That's great. So has anyone got any questions? You can start typing. It depends on how quick you can type. While people are thinking or typing, I think when you're doing the neurovascular observations, in my practice I saw so many people just touching the end of a couple of fingers or something like that, and not fully understanding the nerve distributions in each of the limbs and how you need to check for
Well,
each of those
you're
nerve
just coming out
distributions.
in and out at the moment, Paul.
I'm sorry. Could you get the gist of what I
Yeah,
was saying? So yeah, so I saw people just
I
touching
just
the end.
lost you again, Paul. I'm not sure if you're still there, if it's just me or whether it's for everyone, but it's just we've
Yeah,
lost your audio.
cool. Can everyone else hear me at the
Oh,
moment?
got you back.
Oh, it's coming and going by the sounds.
Oh, no, I've got you back at the.
Okay. Yeah, so I was just saying that in my practice, I noticed people assessing neurovasculars just by touching a couple of fingers right on the fingertips and saying, can you feel that, rather than really appreciating the nerve distributions of each limb and assessing for damage to each individual, especially the three distal nerves in the upper limb as well, is really important. So, it's one thing that's we need. Having a really good neurovascular chart helps with that a little bit, because the ones I grew up practicing with or using was very basic, and the ones that you referred to, there's a lot better ones around there. So if it's something in your practice where you've got a really basic, sensation, pain, blah, 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 and not that level of detail in terms of nerve distribution. So I think that's really useful to have. So try and push for that. Look at that resource from the RCN and have a look around and see what's around.
Yeah, no,
So,
having a good neurovascular chart is certainly very, very important, and it's something, that we can share.
yeah.
Okay, just got a question from Diane. They're saying under no circumstances split plasters, especially if there's a delay. Yeah, Diane, I don't know if you've seen the slides for the compartment syndrome talk that's available on our ANZONA website. There's actually a couple of slides on a research study which they've done as to how much blood gets back into the limb. And certainly if you're splitting the plasters, that's making a big, big difference with them. So um, I would certainly, if I was faced with a limb that I was worried about the neurovascular status, I wouldn't have any hesitation in splitting the plaster, and certainly splitting it bilaterally as well, and making sure that you're going through the web rule and right down through, whatever's under the plaster, because to me, getting the blood supply back into that limb is what's most important. And fractures can be reset, they can be fixed at a later stage, but once you've got neurovascular compromise, you've only got around about half an hour to an hour to work with a limb, because as we know, about half an hour, nerves become damaged permanently, and within about 2 hours without a blood supply, they're irreversibly damaged. So what we want to be doing is getting blood back into that limb. So I'd probably be interested to see what their rationale is for them to not want people to split plasters. Yeah,
They just don't
I
want to do
wouldn't
the
agree.
surgery again. That's why. That's the
Again,
main
it's
reason.
working a team, isn't it? And it's having yeah, it's yeah, working as a team, and
Yeah.
having faith
I,
in your nurses to make that decision.
I understand, there might be people out there who will try and split a plaster and they don't know what they're doing, and they might do it in the wrong spot or for the wrong. There might be slight compromise, whereas you need to have those skills to understand what's serious and what's not so serious. But at the same time, you don't losing a limb is, even if you have to go back and redo the surgery, it's better than not having a limb at all or having a completely non-functioning limb. So you can't just make a blanket rule saying not allowed to split it under any circumstances. That's not right.
Yeah, and I think it's a good argument for defending orthopaedics as a specialty too. Is having specialist orthopaedic nurses
Yeah.
um, looking after those patients that have the experience to be able to make that decision.
Yeah. And I don't,
Rather than being in a general area.
yeah.
Okay, Megan's just saying that they've got an annual competency to protect and practice splitting the plaster. Yeah, and it is. It works really quite well. But yeah, keeping in mind that split it bilaterally and you'll get a lot more blood supply back into that area as well, not just in one spot.
Yeah, so Diane was
Okay,
just
and
saying
Diane's having audio.
you were just dropping out a little bit as well. I think what Megan said is really important because, I don't know about everyone else's practice, but where I worked, a lot of the plaster care and application has moved out of the wards into the outpatient department or to other non-nurses. And what that I think has done over time is decreased nurses' confidence in their skills in terms of managing plaster. So, if you went to an ortho ward now and you asked, 100 ortho nurses, do you feel confident splitting a plaster? There's probably a really big percentage that don't, and that's so different to maybe 10 or 15 years ago. So that might be one of the problems as well.
Yep, so it's keeping a hold of, what is potentially those lost skills within orthopedics is just so important as well. And then I think they will trust our judgment a little bit better with it. But I think, it's not happening commonly because we are actually very good at trying to prevent it from happening. And we are really good at elevating the limbs post-operatively, and so we're not seeing it as often as we could be because we are preventing it, and I think we're good at that.
Yeah.
Okay, so we've had another couple of comments come in there as well, but very much on that, just backing up that same statements there. Have we got any other questions at all on any of what we covered tonight on the neurovascular assessment? We'll just give people a couple of minutes if they do want to type.
No, it looks like everyone's okay.
Okay.
Excellent. Well, thank you, Wendy, for another great session. Like I said before, the recording will go up on YouTube. There will be a link on the ANZONA website. There's always links to the recordings if you need to go and have a look, so you listen to some old ones. The next one is some stage in July, which I'm doing, and I can't remember the date. And that'll be on...
it'll be the...
it's like the 19th of July.
The third Tuesday.
Yeah, the 19th. I just found that. So I'll be presenting on my trip to Myanmar, where I'm going in a few weeks' time, or Burma, if you don't know, it is Myanmar. And we'll be going over there to develop some links with some orthopaedic nurses there. So do that. And Jeanette's hopefully catch you up at the next meeting.
Yeah, which will be lovely. The other thing is, feel free once it has gotten on the YouTube link to share the session with, some of the less experienced staff within the clinical area if you think that they will get benefit from it as well. Because again, it's mainly about the patient care and improving the care that we're giving to our orthopaedic patients. Yeah, so we're, certainly fine for sharing that, as long as ANZONA is, given the recognition for that. That'd be good. Okay, thank you, everybody.
Thanks all for coming along.